You see this equation in the question step, you can easily say, okay, this is lymphoma. What are the things you're going to look out for? Tell me, what are the things you're going to look out for? What are the things? Lymphoma, 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 lymphoma. Tell me, what are the things you're going to look out for? Lymphoma, lymphoma. I'm waiting for your answers. Okay, so Dr. ESTM is starting with lymph adenopathy. Dr. Nandini says nodes. I'm sure she's talking about lymph nodes, right? Dr. Lukichi says B symptoms, night sweats, weight loss, anemia. Dr. Jakilu says fatigue and susceptibility to infections. Dr. Calvin says painless mass, weight loss. Dr. Tolu says daytime and nighttime sweating, non-tender lymphadenopathy, weight loss. So you're thinking about painless swollen lymph nodes, night sweats, weight loss. That's what is going to cause you to think about lymphoma. Okay, let's talk about degenerative causes and drugs. We already talked about cirrhosis with ascites and then drug-induced hepatomegaly, for example, methotrexate, and constipation, which is secondary to opioid use, right? So cirrhosis with ascites, I think this one, we've already gone through it over and over and over again. So I'm just going to mention it. A patient with alcohol history, ascites, jaundice, okay, cirrhosis, which presents with ascites. Okay, those are the features you're looking out for. Look for a patient with a known history of viral hepatitis. What about drug-induced hepatomegaly? Drug-induced hepatomegaly, what are you looking out for? You're looking for a patient who has a condition which is needing methotrexate to help treat it. Looking for a patient who is needing amiodarone. Looking for a patient who is taking alcohol for a long time. Drug-induced hepatomegaly, all right? Drug-induced hepatomegaly. What about opioid-induced constipation? This gives it away. So look for a patient who is on an opioid like morphine, hydromorphone, hydromorphcontin, fentanyl, those drugs. Or a patient who abuses opioids and is unable to poop and now has developed increased abdominal girth. What about iatrogenic? So how will a patient with post-surgical adhesions present? Can you help me? Post-surgical abdominal adhesions and then abdominal distension secondary to retained gas, especially the post-surgical adhesions. How will the patient present? Please, I want to know. Okay, post-surgical adhesions. I want to know how will the patient present, or on the history, how will the patient present? Tell me. So constipation, sure. What else? The patient will not be able to pass stools or flatus, right? Or both. So previous abdominal surgery, abdominal bowel obstruction, and the bowel obstruction, if you look at an abdominal x-ray, you may see, features of bowel obstruction, Holstra, if it is large bowel, you may see air fluid levels on abdominal x-ray. If the patient has a previous history of abdominal surgery and they present abdominal distension, they may even have vomiting, no recent bowel movements. Participation in the class today has been awesome.